Hi, welcome everyone. Thank you for joining us today for Facebook Live, The Future of Implementation Science. We've brought together a panel of DNP executive track students at the Johns Hopkins School of Nursing to talk about implementation science and to learn about their transformative scholarship. What's more, they work while pursuing higher learning and are currently engaged in careers that push the boundaries of healthcare. So moderating today's discussion is myself, Dr. Kim McIltrot, and Dr. Brigit VanGraafeiland. Dr. VanGraafeiland is our DNP Associate Program Director. And now our panelists are here with us today, so I will turn it over to Dr. VanGraafeiland.
Thank you, Dr. McIltrot, and welcome everyone. I would like to go ahead and have our panelists go around and briefly introduce yourselves and what program you're in, and just tell us the title of your project. We'll start with Audrey.
Thanks, Dr. VanGraafeiland. My name is Audrey Kleet. Hi, everybody. My name is Audrey Kleet. I'm an experienced healthcare leader based in the New York metro area. I am a DNP MBA student at Johns Hopkins, graduating in May. Very excited. And the title of my DNP project is Psychosocial Readiness Assessments for Heart Transplant Candidates.
Thank you, Natalie.
Bonjour, hello. My name is Natalie Nicholson. I am from Bemidji, Minnesota, and I'm in the DNP Executive Track Nursing Program. And my QI project is the Indigenous Breastfeeding Counselor, a culturally relevant breastfeeding intervention for Native American mothers.
Thank you. Elizabeth?
Thank you. Hi, this is Elizabeth Hood. Please call me Liz. I have been in healthcare since 2003, been a leader since 2009, and the topic of my project is capturing advanced practice provider productivity in a surgical setting. Excited to be here today. Thank you.
Thank you, Liz. JD.
Hi, my name is JD Murphy. I am a pediatric oncology and bone marrow transplant nurse practitioner at the Johns Hopkins Children's Center in Baltimore, Maryland. I'm in the DNP executive track, and my project is on optimizing nutritional support in pediatric BMT patients.
Thank you. Chivas?
Hi, my name is Chivas Guillote, and I'm a DNP executive student. Several of us graduate in 2 months and 20 days, but who's counting? I'm a nurse practitioner working in pre-hospital emergency care and also emergency medicine. I divide my time between EMS leadership, and I'm also an NP in a small critical access hospital in East Texas. And my project title is a clinical bundle to reduce peri-intubation hypoxia in the pre-hospital setting. Thanks for coming today.
Thank you. And last but not least, Alainna.
Hi, my name is Alainna Crotty. I am an adult gerontology clinical nurse specialist with the Armed Forces, and I am in the DNP nurse executive track. My DNP project is preventing pressure injuries in adult medical surgical patients through innovation, and I am excited to be here with everyone.
Great. Well, thank you all so much for participating. You certainly have a lot to talk about, both in your journey through the DNP program and with all of your hard work improving systems and patient outcomes. So can you tell me just a little bit, and I'm going to open it up to the group, so feel free to unmute yourselves and discuss, but why the DNP? What made you pursue the Doctor of Nursing practice, and the role any implementation science played in the translation of your project to the organization?
I'll go ahead.
I'll jump in here. I'm sorry, Chivas.
Oh, sure.
Go ahead.
No problem. So in my EMS system, we are always trying to grow and improve in the quality of care that we deliver. And EMS is a little bit less mature of a specialty as compared to emergency medicine or nursing. And we have really done a great job as an industry in improving the level of science that we utilize in our practice. And DNPs are really well adept at being able to understand the local problems in an EMS system or a hospital system, and for leaders to find areas where they can improve and to use evidence-based practice to bring those changes from the research arena into practice in a work setting.
Thank you,
Well
Sheila.
said.
Yeah.
He's a tough act to follow. I think for me, a DNP was sort of an obvious route. I will say I grappled for years between PhD or DNP, and what really sold me was the Hopkins offering of the dual degree program with the DNP executive track with the MBA in the Carey Business School. And, as you develop and grow as a nurse and as a leader, because nurse practitioners lead in their practice, in their care of patients, in their workplaces and outside of their workplaces. So the DNP just was an obvious fit for me in my career, and very proud to be attending Hopkins in this dual degree program.
Thank you, Audrey.
I have to agree with Audrey. I also spent years grappling between PhD and DNP. And for me, it was the alignment of the DNP executive program with some of my other interests with economics and finance that really sold me on this program, in addition to the really amazing faculty that I had heard so much about. And my work is all around improving hospital systems and trying to bring more evidence to how we practice. So I think utilizing implementation science has only strengthened the work that I have been doing in hospitals for years. And I'm incredibly grateful to have learned it along the way.
I'd like to share a little bit about why I decided. I had never planned on going back and getting my doctorate degree like some of you friends of mine here. But it really changed for me being a nurse practitioner in family practice for over 12 years on one of our local reservations. And our hometown is in the middle between 3 reservations of Ojibwe Moan folks. But for me, it really was coming down to job satisfaction, really trying to make changes for the Indigenous population in my community. And I think it's really important and a responsibility as an Indigenous scholar to take those steps and learn some of the skills to go back. So we are leading our own health initiatives and doing it in a way that complements both Western and Indigenous ways of knowing and living. And so I needed to learn some of those skills, and being able to bring it back to the community and having them guide our work and how we provide services and care. So I'm grateful to my community and in our nonprofit organization I work for, Mewaja Unidasig Wigamig.
Thank you. Would anyone else like to share their thoughts?
Sure, I can share. So I decided to go back and get my DNP after I graduated from Hopkins in 2018 with my adult gero CNS. So my colleagues at the medicine that I was working at, some of our CNSs were DNP prepared, and they were inspiring with how they tackled some of the same issues that I was seeing, but was able to go a little bit further in how they implemented evidence-based practice. And I strive to be like my DNP prepared colleagues, which inspired me to go back to school. And Hopkins was an obvious choice because I thoroughly enjoyed my MSN program from 16 to 18. So it was a no-brainer to apply and come back to Hopkins.
Thank you.
So Dr. VanGraafeiland, just to build on what Alainna's saying, and interesting, my clinical practice is in advanced heart failure and heart replacement therapies, such as mechanical circulatory support and heart transplantation. And it's a highly regulated field, and we do loads of quality improvement work. So I think, thinking about DNP versus PhD, it just made sense in practice to to try to get the formal knowledge and skills and methodologies around that.
Thank you. And that's a great segue into our other question that we'd like you guys to discuss for our viewers. So tell me, what your thoughts are on the differences between a PhD and a DNP, and, do you guys collaborate together?
I can start with this one. So the acronyms, so the DNP is the Doctor of Nursing Practice, where the PhD is a Doctorate of Philosophy. And so kind of the focus of each degree is a little different. So the PhD is more of a research centered, where your DNP is more clinical practice focused. But really both roles collaborate very well together. So for me personally, why I wanted to do a DNP is I wanted to focus more on directly at the bedside, improving the clinical care of my patients. And what we've learned throughout this program is that there is a big gap in research to practice. So it's about 17 years on average that it takes that data that you find in new research to actually transition it to translate it into direct patient care. And that's something that I came across while doing my project. So I wanted to be part of making sure that my patients were receiving the most up-to-date evidence-based care.
Great, thank you. Anyone else have any other thoughts on, building upon what JD said? When we do think about evidence-based practice and the length of time it does take to translate the best evidence that we have accumulated into improving health outcomes, one of the big goals of the DNP is to shorten that time frame, to have more DNP prepared nurses to be able to really translate that best evidence.
Yes, I completely agree with what both JD and Dr. VanGraafeiland have said. I think that we really can find strength as a nursing profession when the DNPs and the PhDs work together to bring research and evidence-based practice to the forefront of how we practice as clinicians. And it's been an incredible collaboration for me at my institution to work with the PhDs and to try to coalesce our knowledge into places where it really can impact patient care.
A lot of PhD researchers that do phenomenal work sometimes don't have the benefit of the local organizational knowledge in which their research is geared towards. And so what's really great about having DNPs and PhDs working together is their ability to provide that context that sometimes is missing in a PhD's project by allowing the DNP to give them that local context and understanding. And then the other thing is a lot of great PhD pieces of work never make it into practice. And so it's a really, really great way to honor the work done by PhD graduates and PhDs that are working out in the field by taking that research that they've worked so hard on and bringing it to fruition.
And that's interesting what Chivas just said, because that's how I see this, where we're basically translating that evidence into practice, and we're putting, process methodology around it that leads to a more sustainable nursing workforce. DNPs, we're taking that evidence, we're allowing our nurse colleagues really, and our NP colleagues, and then the multidisciplinary care team around us to benefit from more efficient processes to deliver care to our complex patients.
I just wanted to also kind of highlight a relationship I have with one of the other nursing professors at the School of Nursing, Dr. Teresa Brockie. And she is one of the first Native nurse professors at Johns Hopkins School of Nursing. And being a part of some of her writing accountability groups that's been established, being invited to be a part of that, and also a Native nurse mentorship group that we started together. But my experience has been a little bit different with that, where, I've also utilized her as a DNP, as a PhD, to help even guide some of the work that I do, like in my own community, and things that are to consider like ethically when working with Indigenous communities. And one of her specialties is community-based participatory research, where she is engaged in her community. And that's a whole different process than a little bit clinically what we're talking about. And so I think it's also important to know like the different types of research that researchers do and what aligns with the work that we're trying to do. And so I'm more aligned with that sort of type of research. And I'm always just grateful for her guidance and mentorship, and also my advisor, Dr. VanGraafeiland, as well, as we're going through the process. I mean, I think the expertise that they have, that Hopkins offers, and the accessibility to expert guidance and education has been really phenomenal for me. I never personally thought I would go to a school of this magnitude. So anyone can do it. You can do it. Just apply.
And piggybacking off what Natalie said, so I think the big difference between PhD and DNP is our PhD prepared nurses are our knowledge generators. So they're going to find that gap and they're going to generate some new knowledge that then we translate that knowledge into practice, as many of my colleagues have stated. And I think it's really important to have a PhD on your team, or a mentor, as Natalie was stating, so that when you're implementing that research into practice, if there's gaps identified as you're doing your EVP project, you can bring that back, and then we can go back through the process again and generate the new knowledge that fills in that gap.
So I'm gonna, with that segue, I'm going to have you all talk a little bit about your projects. And then if you can just tell us a little bit how maybe that's impacted your work. And I know you're all getting ready to graduate, and maybe not fully has it impacted your job, et cetera. But maybe just like how you came up with the idea, and then really like what you're doing and what you foresee in the future. So you can just jump on in.
I can start. So my original DNP project was to implement a wearable sensor that patients would wear to track turn compliance. And my project came about as pressure injuries were plaguing my institution. So it was one of the top 10 patient safety priorities for my institution. So it became my priority. And it was one that I could, as an adult gero clinical nurse specialist, it was in my wheelhouse to tackle. But implementing a new system and technology into my institution proved to be a little bit more challenging than anticipated. So we transitioned then to a locally made dashboard that tracks turn compliance based on the electronic health record, or EHR's documentation. So a patient will be red if they're overdue to be turned. They will populate and color code as yellow if they're due to be turned in 15 minutes, and green, they're great, they were charted on, they should be good to turn. So with that, and implementing my DNP project has opened actually a lot of doors as a CNS. So I've been invited to sit on higher headquarters or different level committees than I would have. And I definitely attribute my work on my DNP project to the different opportunities opening for me.
Yeah, I agree. It makes a difference inside your institution when they see the kind of work that you're capable of, supported by these amazing experts. My work actually started out of the pandemic. So it became very apparent very early on in the pandemic that children's hospitals were going to take a pretty large financial hit. And I realized that advanced practice, particularly in surgery, was sort of an invisible workforce, because a lot of our work is wrapped into the global billing period for patients. And so unless you're billing or you're seeing patients independently in clinic and not in collaboration with the surgeon, or you're not falling in that global billing period, your work isn't captured through traditional methods. So just before I had started doing a lit review, looking for other ways of capturing productivity. And when I got to Hopkins, did a very in-depth literature review and found that there isn't a great way to do it currently in the literature. So I took several pieces of knowledge and implemented them at my hospital, including a time study, a dashboard of electronic medical record touches, and a pre-post survey methodology to see if it improved provider satisfaction and workload perception to see their work represented. And we're in the data analysis portion of our work right now, 2 months to graduation. So I'm really excited to see where this takes me.
Yeah, we're definitely excited to see everybody's outcomes here shortly. JD?
Sure. So the problem that I focused on was that of malnutrition. So in the pediatric oncology world, it is a big and a modifiable risk factor to have malnutrition at any time during your cancer treatment. And we need to do anything that we can do to try to get better outcomes for these children. So I did a lot of research on specifically the pediatric blood and marrow transplant patients and nutrition support and how to decrease rates of malnutrition and also best ways to provide nutrition support. So you have enteral nutrition, which is, eating or using your gut by means of feeding tubes, or you have parenteral, which is giving IV nutrition. And for many reasons, most patients that undergo a lot of chemotherapy, and especially bone marrow transplant patients, they get most of their nutrition through the IV route because you're having a lot of GI toxicity and you're just not able to tolerate much, is what the historical approach has been. And so my focus and my goal was to try to change the global feel of the division to try to see if we can shift that a little bit and provide any means of nutritional support. And what I found out through my research before implementation was actually that it's not an all or nothing thing. So any small amount of enteral nutrition is going to benefit these patients. And so that was really the big takeaway that, let's try to even get trophic feeds or some sort of means in. So after giving lots of education to our multidisciplinary team, I was able to get all of our doctors, nurses, child life specialists, psychologists, dietitian, everybody, social workers, everybody on board to prepare these patients and families well in advance of their transplant that they're going to have feeding support of some way, either an nasogastric or like a gastrostomy surgical tube placement. And then I created an algorithm that these patients followed throughout their transplant admission to try to, using evidence-based support, feed them as much as we could. And it worked really well. We found some things that we're gonna need to change in the future as far as like better securement of feeding devices, but it really change the culture to make this just as important as making sure we have the right chemotherapy prep and everything else that goes along with the transplantation. So I'm really excited to see how much further we're going to be able to grow this within my division and across the pediatric oncology world.
That's wonderful. And I love the multidisciplinary work too. Great. Shiva.
So although I mentioned in the intro, I'll just remind people that my role is a little unusual in that I don't work full-time as a nurse practitioner in a hospital. I work in a leadership role in pre-hospital emergency care, supporting about 180 paramedics in North Houston at a system called Harris County Emergency Corps. And EMS patients are a little different in that they are often under-resuscitated and they call when there's an acute medical emergency, and unlike other specialties that have the ability to just cancel a case, there's not canceling someone's pre-hospital emergency. So we're often in a forced to act scenario of where we have to do difficult high-risk procedures that have high consequences of adverse events. And one of those adverse events that we frequently encounter is in regards to providing airway management to patients. And so what we know is that in the poorly resuscitated patient, when we take away their ability to move and breathe through a procedure called rapid sequence intubation, we enhance their risk of having low blood pressure, low heart rates, cardiac arrest in the middle of the procedure, all related mainly to hypoxia. And so the aim of my project was to find methods to improve safety during the airway management procedure in pre-hospital care. And luckily the work was really kind of done for us by another very, very successful pre-hospital researcher named Dr. Jeff Jarvis, who in his EMS system in Texas had built a clinical airway bundle utilized during pre-hospital intubation that dramatically improved safety within his system. And this article was published in the Annals of Emergency Medicine. And so when I was doing my literature review, I was able to identify this article as a best practice. And that, in addition to some other items that had come out of my lit review, enrolled that procedure at Harris County Emergency Corps. And preliminarily, I can tell you that our adverse event rate went way down after we implemented this procedure. So exactly what we had hoped would happen is happening. So it's been a great experience so far.
Great, excellent. Audrey.
Thanks, Dr. McIltrot. So like Chivas, I'm, my day-to-day role is as a healthcare leader, and I am the chief transplant officer at New York Presbyterian Columbia University Irving Medical Center in New York. And in my role, I get to oversee the clinical operations of the advanced heart failure, mechanical circulatory support, and adult heart transplant program. One of the gaps I had always found and that bothered me was once we took these very fragile patients from heart transplant evaluation to waitlisting, they were getting all of their usual medical care while living on the wait list, but they weren't necessarily getting a standard pathway for assessing and follow-up care for psychosocial needs, which include mental health and socioeconomic needs. And that's a gap that I felt that we could readily close with a solid process, because we had the right multidisciplinary care team members to deliver this care and to assess these patients in a standard or ongoing fashion. And we weren't necessarily doing so. So it really had to be patient driven instead of provider driven. And so we kind of turned that around. And my project then was really assessing the feasibility of doing this sort of standard programming in asking for standard questions related to 4 socioeconomic domains. So looking at caregiver support, housing, a transportation plan to and from the hospital or clinic, and then financial resource, more specific to insurance coverage. And all of these patients had met our center's criteria prior to being waitlisted. And now it was a matter of sort of keeping up with them while they were living on the wait list. And I really wanted to look at the patients who were not living in the hospital waiting for their organ transplant, because those patients wait days to weeks. What I wanted to do was take a look at those patients who are waiting in a medically stable fashion at home. And again, they would have to drive that care instead of us driving that care for them and checking in. And I will say that COVID really helped sort of push this. It was really a catalyst where we could use the telehealth technology platform to access our patients and for them to access us for these, meaningful interactions to assess the 4 socioeconomic domains, and then to do a mental health screening for anxiety and depression through a GAD-7 and a PHQ-8. It was very interesting. Our transplant coordinators took this on, and we're very excited to make these meaningful connections with their waitlisted patients that they weren't necessarily enjoying previously until the night of the transplant, when they would call them to say, "We've provisionally accepted an organ for you. You need to get to the hospital now." So a lot still to learn in the data analysis and in writing up the scholarly paper, but absolutely we're able to show that this is feasible.
Great. And Natalie.
Hi. Yeah, so in 2018, our nonprofit Mewajah had hosted the second Indigenous Breastfeeding Counselor course, and that was developed by Cami Goldhammer, who is an Indigenous IBCLC, and she also co-teaches it with Kimberly Moore Salas, and they're both Indigenous IBCLCs. And they came to our home community, so they get invited into communities in the Indigenous community, and this training is specific and relevant to people who identify as Indigenous. And so it's a 45-hour breastfeeding counselor course curriculum. And when you're done, your credentials are an Indigenous breastfeeding counselor, but it is a culturally relevant intervention. And it was such an empowering experience that it really got me into thinking more about breastfeeding and the role I can do, because it's really looked at as, Native American mothers have always breastfed. Historically they breastfed, that was the baby's first food. And so even in our community in Minnesota, northern Minnesota, and people residing on the reservations in the 50s and 60s, they continued to breastfeed, like when most other women in the US were using formula. But then, for example, like by the mid 70s, WIC was distributing formula nationwide, but they still didn't reach some of the reservations here until the mid 80s. So that's not that long ago. And those are being attributed not only from WIC, but going back further to reasons that impact culture, breastfeeding as a primary form of feeding their babies. So you're looking at access to traditional foods from colonization, the Indian Removal Act of the 1850s, 1830s, adverse childhood experiences, boarding school experiences where families were pulled apart. And so for me, I think it's important to know, I didn't specifically know what I was going to do for my project. And I had an idea, and I think it's important to acknowledge, like, my advisor, Dr. VanGraafeiland, helping me figure out what would be a doable project during this time period and how to focus and learn the process, because I will always be able to take these skills learned and apply them to other topics that I want to do once I graduate. So I'm always grateful to having her help me focus on it. And then I was able to reach out to Cami and Kim, and Cami to ask permission if they would allow me to use their curriculum, their education curriculum, to adapt, to implement, this education module for my participants in Minnesota. And I'm just grateful for my participants in Minnesota. And so what's happening is that the question I was asking was, what in our literature search that we did within our first year was, what culturally relevant breastfeeding interventions are being used for Native American mothers? And there was nothing in the literature. Now, I knew that there was the IBC, but it's not published. And so that was how there was a gap there. So Native American mothers then have one of the lowest initiation, duration, and exclusivity breastfeeding rates. And so we're looking at how can we close those gaps and better support our Native mothers using a culturally relevant curriculum. And the other thing that's important to acknowledge is really that, we've always had our community birth and breastfeeding knowledge keepers. Those could be our grandmothers, our aunties, our cousins, the grandparents, the midwives. They've always been there and done this work. And supported our moms. And so we want to get back into that revitalization of that knowledge and support.
That's great. So you all just have amazing projects. And, Natalie, you made a really interesting point that I know Dr. VanGraafeiland and I, always talk a lot about to the students. You're here for like a limited amount of time, and a lot of people have like these great ideas that maybe take longer and things like that. So just keeping into perspective of what you can get done here, and then go back and even do larger projects and all of that. But you guys all have such high impactful projects, so it's very exciting. So one thing that thinking about your projects is I'm curious to see how COVID impacted your projects. So maybe if some of you maybe had, can talk about like the positive, maybe a positive thing and maybe like a negative thing of how COVID changed your project, impacted your project. If any of you have anything to add to that.
I can think of a couple of things right off the bat. In my case, I was doing an airway management project in the midst of the COVID pandemic. So in my case, it probably improved my recruitment of patients. which was really interesting. And one of the nice things in the data analysis piece that will be different than the original evidence-based article is that article was done in a time before COVID. And so my results will be maybe a little different in that I have to factor in the COVID factor into the population that I'm taking care of. So that was interesting. Another thing that was interesting that COVID probably contributed to is a little bit of fatigue amongst the providers that were rolling out the bundle. You know, we changed their practice. And when you're comfortable doing a procedure a specific way, and you think that you're doing a good job doing that procedure, when someone comes in and says, hey, by the way, there's a better way to do this, and we're not as good as we think we are as a system, that message can be difficult to hear. And so to motivate people in the middle of a global pandemic to want to change their practice in a way that wasn't their idea is challenging. And I will say that our staff here at Harris County Emergency Corps really has excelled at grasping this change and moving forward with it. And I think culturally, we've moved the needle in a way that's going to make patients safer.
I'll just second the fatigue from staff. I think it's been a real, 2 years at this point, it's been a long slog. But the other thing that impacted my project was just learning from the pandemic that it's possible to gather people without physically being in the same space, right? So even the technology we're utilizing today to gather via Facebook Live was part of my project implementation. Because at the time that I was implementing, we had a huge surge and we weren't allowed to gather in conference rooms and things like that. So I used Zoom and recorded my presentation and then shared it via email with my colleagues so that they would consider enrolling in my project. And I just think having that sort of new knowledge base from the pandemic has been a plus. And I think it helped me recruit participants who weren't physically on campus at the time that I was giving my presentations.
Yeah, like Liz, COVID really informed my project design in that we wanted to deliver these assessments through telehealth platform or via a scheduled phone call so that patients knew we were coming. They knew that they would be delivered this care. And really, other than obviously the multidisciplinary care team fatigue, our program was just bursting wide open at the time that this project was implemented. So our transplant coordinators and our social workers and transplant financial coordinators who really were doing all the heavy lifting with the participants in this project really rose to the occasion and immediately adapted to it because they saw the importance of connecting with the patients. They saw how the patients really were taking in that care and feeling, that they were the patients were eager to hear from us with any information we had for them or any care that we had to offer. So I think it was actually a positive to implement this in the middle of a public health crisis.
Yeah, I know for us implementing using a Zoom platform for me, I'm always grateful to Native people because they always support each other so well when needed. And so when I needed to recruit, I was like, I need help. I'm doing this for school. And, for us, it's really important. We always gather in person and there's that energy that we have, and it's important that we hug and support each other. And there's a lot of participation. And I always think, I'm grateful to my organization for helping in any way that I needed support to continue this project, to implement it through Zoom. We had our helpers at Mewaja that stepped in and helped facilitate and organize, and then the participants as well, in doing and being responsive. And it can be done. And I was happy that it got done, but it's always better. It's always good to do things in person, but we have to adapt, and that's what we do. So.
Yes, echoing what you all have said. So in the midst of my DNP project implementation, I got deployed. So halfway around the world, and I am I wouldn't say grateful, but I appreciate that COVID increased the ability for us to do things via the different internet platforms. So I was still able to continue with my DNP program because my site was very well versed in using MS Teams or Zoom. I think some of the negatives about COVID, which I don't know if it's a negative because it's actually probably helped my practice as a CNS, was to encourage us to be adaptable and flexible. So the unit I implemented my project on was not the COVID unit until literally a week before I went to implement it, and it became the COVID unit. So that kind of changed how many patients I was able to recruit for my project. But so I think it encouraged us to be adaptable and flexible, which will be beneficial for future practice for sure.
Just to finish it off, thankfully in pediatrics, we have not been as affected directly with this pandemic, but indirect things have been that research projects at the Johns Hopkins system across the system have been shut down. And so elective transplants for patients that don't have cancer, might have a blood disorder of some sort, they were all canceled. As well as we get a lot of international patients, and travel was greatly restricted. So we went from having about 50 transplants a year to 20 for the last couple of years with COVID. And so as far as my implementation, it wasn't affected at all, but the sheer numbers of patients that I could do this on was greatly affected. So it's almost like it was a little bit of a pilot study for what I hope to achieve in the future. But yeah, you make do with what you can, as we all have the last 2 years.
I think
Yes,
also like with that, it's like learning the difference between like clinical significance then and statistical significance.
Very good point, Natalie.
Absolutely, absolutely.
Yes, and you guys have all just done amazing jobs, because I know there's been, just so many different, first of all, there's always barriers with projects, but yes, yours were probably exponentially higher, but everybody's been doing amazing, great projects. So I do have one question for actually Natalie. You have a question that came through in the chat. And the person wanted to ask you if you could talk about support available to nurses of color. And I did want to just add this in 2021, our DNP incoming class actually had 43% students of color.
Yeah, that's wonderful. I think my experience is a little bit different because this is an online program. Right. So I'm still based in home with my support systems. And so I truly can't speak to all of the resources that Hopkins offers in terms of people of color for nurses. What I do know is that there is a diversity, equity, inclusion committee. I do see things come through on emails in terms of, opportunities for people to gather and connect. For me, I just work a little bit different in that sense, where I know that there wasn't something specific for Native students within the nursing program. It's just a small group, and hopefully that will change and we'll have more students applying. So when that happens, you have to take your own initiative. And what I will say is that I knew Dr. Brockie prior. I met her in undergrad nursing school, so she sort of recruited me to Hopkins, and so I always felt that connection to be able to reach out. It's also my nature to try to reach out and to access resources that are available. So my undergrad program and my master's program had, things available for Native nursing students. And I think those programs that are established at universities are wonderful. They're important to have, not only just to be able to support students, but to be a reference. We meet monthly for our Native Nurse Mentorship Group, and it's also past students that have graduated, and we meet once a month. And for us, we talk about not only challenges that we have through school, but also work. And everyone's really helpful and supportive and offers suggestions or resources. And so, yeah, thank you for the question.
Natalie, what are you comfortable talking about what the group is going to do at graduation?
Oh, yeah. So you know, it's really, we're doing a blanket ceremony, which is a celebration of something special that happens in Native communities. And so I had one for undergrad and my master's. And so I was telling Teresa, I was like, so are we doing like a blanket ceremony and a traditional meal? And she's like, well, we should, we can, you know, so that's something that we're working on. And so it's going to be the first one. And I know it won't be the last. And so that's going to be the afternoon after our School of Nursing ceremony. And what we've decided is there's 4 of us students. So there was 2 that had graduated the year prior. So I think Timmy and Godfrey was the first one. And then there's Amanda Wyatt from last year. And then there's myself. And then there's also another student, Kyle Durant. And so what we will have done is that there'll be a traditional meal. So we're each kind of planning from our region to share a traditional meal with each other. And then they'll have the blanket that's made, which is Teresa's organized, and it's the JHU colors. And there'll be an elder giving a blessing, and there'll be a traditional song. And so I'm really excited to do that and have my family come. And it's going to be at the courtyard that has the land acknowledgement, which is beautiful. And so, yeah, I'm excited for it.
Yeah, so am I. So thank you for sharing that. So we have a few minutes left. Like to ask one more question, and then we can go around and just kind of, you know, finish up with any thoughts you all may have. But can you think of any opportunities or mentoring that you were able to take advantage of when you were at Hopkins? And was that one of the reasons that you chose Hopkins?
So I can start. I had the fortune of Dr. VanGraafeiland to be my advisor for this. And so it has been huge throughout this program to feel like every step of the way we have support through this. Our faculty met with us every other week, if not every week. Natalie can also attest that sometimes they turn into more of therapy sessions and helping us stay off the ledge, which is exactly what we all needed throughout this. But if anything, any hiccups came up with our projects, we knew that we had faculty there to support us every step of the way. And that was one of the big reasons why I chose Hopkins. And also, not all DNP programs allow you to do your project where you work. So to be able to do that and to directly impact my patients while completing all of this has been huge. The other mentorship that I've taken advantage of is I hope to go into nursing faculty after completing this and getting my nurse educator certificate as well. And so I've been able to learn from the best and have lots of PNP leaders in the field to guide me along this way. So it's been great.
Great, thank you.
You know, for me in the DNP MBA program, I'm in the second cohort. We're very proud of being the second cohort. Second, we're better than the first. Just saying, sorry for all the first who are alumni, but we're better. But we came in with this sort of mentorship. Really just the structure was there, the stage was set. So, you know, between nursing and the Carey Business School, yeah, we had, this was pre-pandemic, so we had, you know, in-person get together, and we had business residency, and along with that, we had nursing immersion. And one of the really nice things that we had again prior to the pandemic is we had lunch together as the 16 of us in the second cohort, the 16 of us students, and then with our faculty. So it was Dr. Vincia Pandian, and it was Dr. Kevin Frick from the business school, and Dr. Bar Orr from the business school. And we literally all just sat in, you know, a conference room at the business school. We enjoyed lunch together, and we just got to know one another and how we all made our way there. And so those opportunities really led to more. So I have, I guess, an unofficial mentorship relationship with Dr. Kevin Frick from the business school, and also with Dr. Ken Dion in the nursing school, who is just an incredible leader in business and in nursing. And Hopkins, just all of you, Dr. VanGraafeiland, Dr. McIltrot, you're always right there for us whenever we need something, and you're always encouraging us to be able to strive for what it is that we want to do. A little bit building on what JD was saying, my academic advisor is Dr. Carmen Alvarez. And, you know, when we have our weekly meetings, it does turn into sometimes a vent fest, but it's a facilitated fest, and she's great. She's very supportive, and she helps give us tools and resources to help us break down the barriers with our projects and keep us moving forward. So a lot of mentorship and support in the Hopkins community.
Yeah, I completely agree, Audrey. Dr. McIltrot was an informal mentor of mine for years prior to joining this program. She and I share a background in pediatric journal surgery, and she was the editor of a journal that I took over for her for a transitional period. So she's an incredible mentor in general. And then I had the great privilege of working with Dr. VanGraafeiland after she was assigned as my advisor, and it's been incredible. In addition, Johns Hopkins offers a nursing executive leadership mentorship opportunity. It's a formal scholarship program. And I was so blessed to be chosen for it and assigned a formal mentor of my choosing, which has been just an incredible experience for me. I was assigned to Dr. Laura Wood from Boston Children's Hospital, and she is the chief nursing officer there and is a Hopkins alumni who actually had the same fellowship opportunity 10 years before. And I didn't know that when I selected her. So it's been a really incredible relationship, and it's really furthered the way that I think about my career, not only from the DNP perspective, but from the leadership perspective and the children's health perspective. So that's been probably one of the best experiences of my DNP program.
Great, thank you for sharing that. I believe also, Alainna, you also are a recipient of that scholarship.
I am. So I was going to echo what Liz has said. So my faculty mentor, or the mentor that I chose was Dr. Kenneth Dion. So I took his digital innovations course this past summer and absolutely adored the elective course and wanted to pick his brain and be Dr. Dion when I grew up. So it has been awesome getting to know him in the mentor-mentee relationship. And I'm excited to see how this continues over the next approximately 8 months. And then another opportunity that I have thoroughly enjoyed at Hopkins is being a teaching assistant. So I applied for that around last spring semester, and I've then been a TA for about 4 courses. So that's an opportunity that exists for students. And I've thoroughly enjoyed getting to learn the MSN entry students, some fellow DNP students by being a TA with the hopes of eventually going in to be faculty somewhere with higher education. So it is the perfect opportunity to have mentors from the faculty that you are a TA with as well.
Great, thank you. So I think as we wrap up, if you would each share your one key point or key to success with us as you begin to start to transition to a graduate of the Johns Hopkins DNP program.
So I just wanted to first off just get a chance to say how much I've enjoyed having a chance to interact with the faculty, that I didn't have any relationships at Johns Hopkins before I applied to the program, but I knew the school was exceptional, and I was so pleased to be selected as a student in the cohort that I'm in. It's been a really, really nice experience, particularly working with Dr. Carolla, Dr. Pandian, Dr. McIltrot and Dr. VanGraafeiland have always been really, really supportive mentors in the program since it started. So thank you for everyone's contribution to that. If I was to make one suggestion as you're thinking about coming into the DNP program, is although your literature review that you're going to do is going to help inform your project, it's great to have a project in mind and to remember that you're not looking to do your life's work with your first project, and that, to quote a statement that Dr. Baker likes to use, is to not attempt to boil the ocean, and that really your first thing that you should do is low-hanging fruit, something that you can easily implement in 12 to 16 weeks. And when you get done with the program, then go save the world. So that would be the one piece of advice that I heard early on and was able to use to my advantage in my project.
You got a lot of head nods on that one.
Great advice.
I think the only thing I'd add, Chivas, is make friends with your counterparts in the class. I've been incredibly fortunate to have met some of my best friends from this program, even during the interview process. So I would strongly encourage, if you're considering coming into Hopkins, to make an effort to reach out to your peers. These relationships are invaluable.
Can I tell on you for a minute, Liz?
Yeah, of course.
So Liz and I were there for the same interview appointment. And I remember looking at Liz and she was all dressed up in a power suit and she looked amazing. And I was there and I was sitting there thinking to myself, I think she's really smart. And if I don't get into school today, it's because I lost to her. And so I was so thrilled that we both got in the same program. And I really have had a chance to connect very closely, Natalie and Liz, and to a lesser degree with everybody else, but I've really, really enjoyed getting to know everybody.
I thought I was going to definitely lose the opportunity to go to this school because of you. So the feeling was absolutely mutual.
And I would just echo off of what Chivas was saying, that I think that you probably can change the world with small projects like we are. You don't have to be in the lab finding the next cure for cancer. You can do something as simple as dropping NG tubes and improve these patients' lives. So just keep that in mind.
I love that. Yes. You know, again, they don't have to be huge, just improving your patients and your unit and your organization and your town and your county and the state, you know, is incredibly worthwhile and incredibly valuable.
I think an important piece of advice is to communicate and over communicate, especially with your faculty as you're going through the DNP project. So life happens and everybody is human. And if you communicate, my faculty members have been more than flexible with me, as again, I got deployed in the middle of my DNP project over to Africa, and I was there for about 8 months, and I'm graduating in about 2.5 months now because of their willingness to work with me in my unique situation. So communicate your needs, obviously within reason, but over communicate as much as possible.
And I so agree with Alainna, and she took the words right out of my mouth. Make sure you communicate, and not only your struggles and barriers, but also your goals and what you're hoping to accomplish. Because of the supportive community at Hopkins, your peers, your student colleagues, and the faculty, everybody's willing to help you reach those goals and surpass those barriers.
Yeah, I think I've had some unique experiences. You know, I think it's so interesting, the ability to take our electives at any of the other schools. So like I love taking a class. I took a couple classes through the Bloomberg School of Public Health, and you have your head in a hole if you don't know about any of those other programs that Hopkins offers. But that and I took some courses through the Center for American Indian Health, and it was the first time I ever had all Indigenous faculty teaching, and it was a crushed, 1 to 2 week condensed course, but it was great. I also think just the connections that, how well connected our faculty is with one another. And so even if they can't provide, the specific, information that you're looking for, they'll help connect you to people that can help. And I was really impressed by that. And so I think that's really valuable and even now, just being able to, last time we had our advisor meeting, I asked Dr. VanGraafeiland to hang on for a little bit. And I just wanted to talk to her a little bit about some of the things that I wanted to do at work and just get some guidance and feedback about the process and what we've been learning, and then still how to just kind of process that through and how to keep it moving forward in my workplace. And so I personally have felt supported, and I think that's really unique as well. So I thank you, you all for that. And then also the support of scholarships and grants, right? To be able to go to school, to be here, and to acknowledge those people that have helped support that.
Great. Well, thank you all so much. Dr. McIltrot and myself really appreciate you guys taking the time out to have this discussion with us and to really promote the DNP role and, you know, what that means from a healthcare perspective and from a national and global perspective. So thank you. We know you're all incredibly busy, so we really appreciate it.
Yes, thank you to all of you for joining us today, and to our audience also, and just for all of our students and your strong work, your great work, and we're just really excited for you all. So thank you.
Miigwech. Thank you.
Thank you.
And I'm stopping the live. Don't log off.